Yes.
Okay. Sorry for this technical issue. This is my disclosure. So as you know, liver biopsy has been the gold standard over the last 15 years. However, it has many limitations because it's impractical given the high number of patients, especially for NAFLD, and the limited number of hepatologists and pathologists. It's also invasive, prone to morbidity and mortality, although rare. Sampling variability, it is expensive. Thus, it's unrealistic and risky. Non-invasive tests are now recommended by all international guidelines, including the APASL guideline. So these are the available invasive tests, two different but complementary approach. The biological approach based on the dosage of serum biomarker. You have two kinds of biomarker, non-patented, simple biomarkers such as Fib4, for instance, and patented. Then the physical approach based on the measurement of liver stiffness with 4 different elastography techniques, ultrasound-based elastography techniques, such as vibration-controlled transient elastography was the pioneer, but RFE, 2D shear wave elastography, and MR-based elastography like MR elastography. So this is the outline I will be following within the next 20 minutes. There are critical issues when using non-invasive tests. I will deal with evidence in cirrhosis, use in clinical practice, and before concluding, just a few hints regarding fibrosis regression after treatment using non-invasive tests. So the critical issue when using non-invasive tests are availability, cost, applicability, and context of use. And this is paramount when you're using this test. So how does it apply? So for instance, if you look at the different available tests, of course, Fib4 is widely available and very cheap as compared to MR elastography. And this makes a lot of difference in your clinical practice because the different tests that you're going to use are going to depend, of course, at their availability at your clinical center. Applicability is defined as reliability and failure rates. And if you look at 2 different tests, for instance, applicability of serum tests, such as the fibro test or other tests, is very high. Whereas for FibroScan, initially, when using the mProbe, applicability was much lower, 80%. If you look at the applicability of the different elastography technique, it's pretty similar, but much higher for MR elastography and RFE. And when using the ESL probe, transient elastography is quite similar to the other. There are confounders of liver stiffness, the 2 main confounders being obesity, as I mentioned, and we get back on this, and inflammation. So this is a summary of the limitation of the different elastography technique. Basically, the confounders are all the same apart from iron for MR elastography. Steatosis is still a matter of debate. Quality criteria are extremely important and they're well defined for transient elastography, but not as well defined and consensual for the other technique. Failure rate, I already mentioned, is very low with MR elastography, and with RFE is higher with 2D shear wave and transient elastography. The units are different as well as the scale, which might be confusing for the clinicians. So the quality criteria need to be better defined for RFE and 2D shear wave elastography, and there's a need for standardization of unit between the different platforms. Context of use. This is a very important issue. Let me remind you that the PPV increase according to prevalence and NPV decrease. So for instance, if we look at NAFLD, now the most prevalent disease, you can see that the prevalence of advanced fibrosis, what we are screening for in liver clinic, is around 20 to 25%, whereas of course it's much lower by 1 log in the general population. How does it translate? So for instance, if you have a test with high negative predictive value, you see at a prevalence of 30%, your test will have a PPV of 70%. Whereas if you're in primary care, where the prevalence is low, then you can see a dramatic decrease in PPV. This has been well illustrated in the study from Asia, multi-center study, 10 center, and you can see with the Fib4 and the NFS, the most popular test in NAFLD, At a prevalence of 50%, PPV is high. Now, if you go down to less than 5%, you see a dramatic decrease in PPV, 12% and 30%, which is not acceptable, meaning that you need a second test to confirm your cases. So this is very important if you want to test your patient in primary care. And let me remind you that most non-invasive tests have been designed and validated only in liver clinic. So what do we have as an evidence in cirrhosis? The most important endpoint, let's say advanced fibrosis and cirrhosis. In viral hepatitis, for serum biomarker, as you can see, we have large meta-analysis, several thousand of patients, and OROCs around between 0.73 and 0.87. One of the issues with the patented tests, they are mostly not independently validated in meta-analysis. Regarding elastography, you can see the OROCs are much higher, above 0.90, whatever the technique, but again, the most validated one is VCTE. What about NAFLD? So the most popular biomarker, non-patented at FIB4 and NFS, and ELF as a patented marker has been also validated. But when you look at the head-to-head comparison, although they have very similar performance or slightly higher as compared to FIB4, widespread application may be limited by cost and availability for ELF that is not available in many countries. What about elastography? Again, if you look, the most validating technique is VCTE, and again, you have very high OROC above 0.90. So how should we use this test in clinical practice? These are the APASL guideline published now 5 years ago for HCV, and I won't go into detail because this is well known. You can combine two tests and just do a liver biopsy when they are discordant. For HBV, these also are the recommended guideline, and transaminase, of course, are very important in HBV, much more important than in HCV or NAFLD. And for instance, at the left of the screen, they are very useful in inactive carriers to exclude significant or advanced fibrosis. On the opposite, when the values are high, they can rule in cirrhosis. Now let's move to NAFLD, of course, the hottest topic currently. And this is, there is no consensus algorithm, but this is an algorithm that we have proposed with Miriam Friedrich-Röst and Rohit Lumba. So most of these patients in first-line RC, either in primary care or by the diabetologist. And of course, you must rule out other causes of liver disease, alcohol, and viral hepatitis. To rule out advanced fibrosis, you should use a serum test, and their FIB4 and NAFLD fibrosis score are the most suited for that. When FIB4 is below 1.3, for instance, you can see the risk is very low, the negative predictive value is very high, as I already showed you, and this is around 55 to 60% of patients. And you just need to obtain lifestyle modification and exercise, and you might repeat over the time. When you're in between, this is intermediate risk, and this is about 30% of patients. And when you're above 3.25, this is high risk. However, if you want the GP to screen your patient and to use this test, I think you must come with a very simple message, is below or above 1.3. If you have two cutoff, it will never work. So you have to be ready to have probably an over referral in patient with intermediate to high risk. The second line, of course, is the hepatologist. So if we are to use the patented test, that a little bit more specific, but less available and more expensive, let's see how it performs. In this study, where there's a head-to-head comparison of the different patented versus non-patented tests, basically what you can see is there is a slight improvement in accuracy, but again, as I mentioned before, widespread application is limited by cost and availability. And there's no independent head-to-head comparison, when I mean independent from the developer of the test, because this study was from Jérôme Boursier that has developed the Fibrometer. So what about the elastography technique? This is a table summarizing the evidence in NAFLD. And again, you can see the level of evidence is the highest with transient elastography, for instance, as compared to MR elastography, even though MR elastography tend to be maybe more accurate. You can detect facts with transient elastography, with CAP or PDFF. The failure rate, as already mentioned, is around now 3% with the XL probe. The major advantage of transient elastography is that it's a point-of-care technique with immediate results, widely available at an acceptable cost. So in practice, this is the most widely used technique in most centers worldwide. What about the comparison between transient elastography and serum biomarker for the diagnosis of cirrhosis? In general, not only for transient elastography outperforms serum biomarker for diagnosing cirrhosis. Now, how does it work in clinical practice and which cutoff should we use? You can see if you're below 8 kilopascal, the negative predictive value is very high, above 90%. If you're above 10 kilopascal, so this is the KD definition, you can see that the PPV is a bit disappointing. It's not very high, between 46 and 64%. If you increase the cutoff to 14 kilopascal, you slightly increase the PPV, but still it's less than 75%. And this is an issue that we are not facing, for instance, in viral hepatitis. What about the probe? Which one should we use? This is a study from Vincent Wong, published last year, large cohort of biopsy-proven NAFLD. And as you can see, there was no difference in terms of box plot between M and XL probe. And when you look at the OROX, they were similar and there was no statistical difference. So the message and the recommendation, if you're using properly the M probe in patients with BMI below 30 and XL probe in patients with BMI above 30, you will yield identical medium LSM and you should not adapt the cutoff. I think this is an important message for our practice. So back to our algorithm proposal. Then you're going to use transient elastography with the XL probe to rule in advanced fibrosis. As I mentioned, if you're below 8 kilopascal, the risk is low. Again, you have standard lifestyle modification and you consider to repeat. It's easy to repeat, let's say every year, for instance. If it's above 8 kilopascal, you're in the intermediate to high risk zone. And then you might consider liver biopsy in these patients according to the treatment that are available in your center, and if your patient is eligible for a therapeutic trial. In case of failure, then you might consider other technique or other biomarker. So before concluding, I would like to say a few words regarding the assessment of fibrosis regression after treatment. This is another hot topic, especially in NAFLD. So ideally, this is the way we would like to see things, with a placebo-controlled study and seeing a decrease in liver stiffness at the endpoint, let's say week 48 or even later, and paired liver biopsy showing a decrease in fibrosis or fibrosis regression. So what have we learned from the viral hepatitis field? Because this is where it all started. And we have this meta-analysis, so 24 study, around 3,000 HCV patients treated either with interferon and DAA. Actually, 10 studies treated patients with DAA. And the message is that liver stiffness using transient elastography decrease in patients achieving SVR. However, there are several caveats to these studies. They are mostly retrospective, with small sample size, mostly interferon-based, short follow-up, and most importantly, no paired liver biopsy. And this is a critical issue because it's very likely that the decrease in liver stiffness is mostly related to inflammation and not to fibrosis regression. So this is another study that comes from China, multi-center study, large study with paired liver biopsy, prospective, in patients treating with NUC. And this is quite interesting because you can see the decrease in liver stiffness between baseline and 78 weeks, so quite a long follow-up. And basically what is interesting is you can see whether there's liver fibrosis progression, liver fibrosis stable, or there's regression, there was decrease, but there was no significant difference between the three groups. So in other words, liver stiffness cannot currently predict liver fibrosis regression under NUC in HBV because of inflammation. You also have to take into account the variability of repeated transient elastography measurement. There are not many studies actually in the literature. This is a study from France on the group of Thierry Poinard for more than 500 pair liver stiffness, less than 1 year in 452 patients. And basically what you can see, there's a variation of more than 20% in 50% of patients, more than 30% in around 1/3 of patients. And these variations were mostly related to the operator, to the probe also that what you, and to the comorbidity. So this is also another issue in the placebo group of the variability of liver stiffness measurement using transient elastography over time. Finally, in this study, the message is that the cutoffs that were usually used to diagnose cirrhosis had low sensitivity after SVR, and this is another issue in practice that we can discuss later on. So just to summarize, in viral hepatitis, eradication of virosuppression is associated with decrease of liver stiffness over time. In the absence of pair biopsy, it's difficult to discriminate whether this is related to improvement of inflammation or fibrosis. And the message is that liver stiffness cannot be currently used as a good surrogate of cirrhosis regression. Let's have just a couple of slides regarding liver stiffness decrease over time in NAFLD, because this is now basically what is used in the trial. So this is, as you can see, a small study, 13 NAFLD patients with transient elastography and MR elastography. And basically, between baseline and follow-up was a short follow-up, week 16. You can see no difference. This is another study. These are the Gilead study from Rohit Lumba. Again, small sample, 44 NAFLD patients using MR elastography. And you can see between the responder and the non-responder, there was no significant difference in terms of liver stiffness. So these are my take-home messages. Choice of non-invasive tests should be guided by local availability, cost, and context of use. There's a technical issue. The animation is not working. Okay. FIB4, NAFLD fibrosis score in NAFLD, and transient elastography are the most accurate, widely available and validated non-invasive method for identification of patients with cirrhosis. The currently optimal strategy is the sequential use of serum biomarker. FIB4 is probably the most suited to primary care because it's very simple, transaminase and platelet and age. And the negative predictive value to rule out cirrhosis is very good. Then as a second test, transient elastography is probably in secondary care the most suited so far to confirm cirrhosis, or in patients with any doubt, select patient in whom liver biopsy may be considered. RFE and 2D shear wave elastography are becoming increasingly available and validated. M elastography is very accurate, but not ready for the clinic and more suited for clinical trial. And finally, non-invasive tests have limited accuracy so far in monitoring fibrosis change in response to therapy. Thank you very much for your attention.
Thank you very much, Professor Castera, for your excellent talk. So, ladies and gentlemen, if you have questions regarding this talk, please use the Q&A or chat function. So we have got the first question. So, so this is an interesting and difficult question, particularly because the definition of acute on chronic liver failure is quite different between Asia and also Europe. So what is the clinical utility of elastography in ACLF?
You're right, this is a difficult question. Actually, for instance, in our center, we're not using it. I'm not sure it's clinically useful in ACLF, and I haven't seen much data actually so far in this particular setting. So I'm not sure it's clinically useful. I don't know what is your opinion, because we might have a different opinion, because you know ACLF etiology are different between Asia and Europe or US.
Yes, most notably in Asia, we require a different definition because hepatitis B reactivation is a common cause of ACLF. So in such individuals, because of the necroinflammation, elastography may not be accurate and can potentially be misleading. And I also tend to think that markers of liver function rather than the physical stiffness may be more relevant in this context.
Yeah,
okay, the next question is about the indication for liver biopsy in NAFLD patients.
Okay, so again, there is no consensus, I think, worldwide among experts. And probably, I don't know what it's like in your center, but in my center, it's very difficult to reach a consensus on the indication of liver biopsy. So of course, you need a framework and you need some recommendations. So as I mentioned, I think above 8 to 10 kilopascal, you might discuss an indication for liver biopsy. But the indication will really depend on the availability of liver biopsy in your center. Is it easy to perform? If you have trials, and is it going to change the management of your patient? If it doesn't change the management of your patient, I'm not an advocate for liver biopsy.
Yes, in fact, this is also what we have been doing. So at our center, if the liver stiffness is below 8 kilopascal, we mostly wouldn't perform liver biopsy. We would even refer the patient back to primary care for the management of the metabolic profile. On the other hand, we tend to discuss liver biopsy when the liver stiffness is over 10. Okay, and next question is on the use of elastography in children. Are there data?
Yes, there are data. Actually, I restricted my talk to adults, but there are data that are pretty similar to what has been reported in adult, but in smaller sample, because as you know, in pediatric population, it's much harder to perform a liver biopsy.
Yes, indeed. So the next question is also a hot topic about the use of non-invasive tests and the assessment of portal hypertension. So probably related to the Baveno 6 criteria. And if I may add, what is your opinion on the added value of spleen stiffness measurement?
Okay, yeah, I did not go into detail regarding this because of course I have to focus for the sake of time. This is of course a hot topic. There have been quite many studies actually on spleen stiffness, but so far, most clinicians have not seen, it's not clear what is the exact role and place of spleen stiffness in clinical practice. So there might be an added value of combining liver stiffness plus spleen stiffness because you're measuring different things. But there's, again, no consensus on how spleen stiffness should be used in patients with suspected portal hypertension.
Yes, and I would also add that it is rather difficult to measure the spleen stiffness compared to liver stiffness measurement. So in NAFLD, in clinical practice, can we start pharmacotherapy based on non-invasive tests alone? So for example, if a patient has high liver stiffness, would you just start pharmacological treatment right away?
I don't think you can do such thing currently. First, because of course there are no drug approved apart from the usual loss of weight and exercise. And currently in the trial, they're all based on liver biopsy. And also it depends what is your endpoint. Are you aiming at resoluting NASH or improving fibrosis? And there have been some attempts with several non-invasive tests, such as a FAST score, for instance, from Ecosens, or the recently presented last week knee score from another pharma company. So basically trying to identify patients with NASH score above 4, so let's say patient with NASH and significant fibrosis. And basically the performance are not bad. I mean, they're OROX around 0.80, 85. with independent validation in different groups. But the question is whether on individual basis you're going to use it. And another issue, as I mentioned in my talk, is the cost, is the availability, and the context of use, because so far, all these tests have been validated in liver clinic, not in all coming patients in primary care, for instance. So these are interesting data, but of course they need independent validations to be able to use them in our clinical practice.
Yes, I fully agree with you. For example, for the NIS4 score that you have just mentioned, you also need to measure microRNA. So even if it is great, it is hard to imagine that it will be available at the primary care setting eventually.
Absolutely.
Okay, so there's one question on the effect of race and ethnicity on liver stiffness. Is there any data on that?
Not really, but probably through BMI, let's say, for instance, between Asia and again, Europe or US, the BMI are usually lower, for instance, in NAFLD. But I'm not sure there is ethnic differences, basically.
Okay, so I would like to ask one final question. So in clinical trials, now for phase 2b and phase 3 studies for NAFLD, we are relying on paired liver biopsies, whereas non-invasive tests may be used in early phase studies. And from the angle of pharmaceutical companies or investigators, of course, they want earlier readouts. So if they want a shorter study to predict whether fibrosis regression is possible, what test would you recommend and how short can it be?
I would not recommend any test as so far. I mean, MRI-PDFF works very well for steatosis. But again, we don't really know whether steatosis resolution or decrease, let's say at 12 weeks or 24 weeks, is related to heart clinical outcome. This we don't know. Same for liver stiffness. So MRI elastography is the most popular technique, but of course it's restricted to highly expert center and only in clinical trial. And I'm not, so far from the data I've seen, I'm not completely convinced that we can use this technique because they're surrogates and they are not validated, again, hard clinical outcome.
Yes, indeed. So once again, thank you very much for your excellent talk and also the enlightening discussion. So we wish you well and thank you very much.
Laurent, before you get off, I really want to ask you one last question, see if Vincent agree. Liver fibrosis is the most important prognostic factors for all chronic liver diseases. And you give an excellent talk of how it could be measured and assessed. Now, I would like to learn from you, what would you think would be the future of placing of this involvement of these tests in the algorithms of the management of patients with liver diseases, especially in Asia Pacific region? How would that help in the management in the future?
So, for instance, something I would foresee, but we don't have any data so far, because this is a very common situation. Patients with HCV cirrhosis that are cured with DAA and that are still at risk, even smaller, of developing HCC. And of course, you would love to have a technique or a cutoff, let's say, for liver stiffness, telling you this patient does not need to be monitored anymore because its risk is below, let's say, 0.1%. And this we don't currently know.
Can I answer and ask the question, Laurent, and enjoy your talk? Yes, in 2015, the APASL guidelines on hepatitis B proposed as the first guideline that LSM above 8 is close to stage 2, and anybody who has a family history of hepatitis B or cancer in the family and all those risk factors, and is above the age of 35 and LSM is above 8, is like stage 2 fibrosis and above. So we recommended liver biopsy in anybody with LSM above 8. This was the general consensus. We would certainly need to validate it. But this is for hepatitis B. We haven't done for NAFLD. So I would like your opinion, and I think APASL also has a similar nearly 8 for hepatitis B. Is that correct? And if that is true, should we not have collaborative studies on at least Asia and Europe?
No, absolutely. I mean, of course, you have much more experience than we do in Europe and also in the US regarding hepatitis B, because this is where the patients are. I think in Hep B, again, non-invasive tests are very useful for inactive carrier. So HB antigen negative, this is most of the patients we're seeing. And when you need to make a differential diagnosis, I think this is very useful to use liver stiffness in this patient, and also because they have normal transaminase, you're not polluted by inflammation. In other situations, I think you still have to be careful, especially with liver stiffness, because of inflammation and the risk of false positive. So I still perform liver biopsy in my HBV patient, not all of them, but on an individual case basis, depending, it's going to influence my management, it's going to change my treatment indications, for instance.
Thank you.
Okay, thank you very much. So, and now we will pass the time to Professor Sheng-Tai Fan to introduce the second speaker. Thank you.
Yes, thank you. Ladies and gentlemen, I have the great pleasure to introduce Professor Kyungsuk. He is the chairman of Department of Surgery, Seoul National University College of Medicine, and he's also the chief of Seoul National University Hospital Transplant Center and director of Seoul National University Cancer Hospital. Professor Su is a very famous liver surgeon. He contributed enormously in the past years in the field of liver transplantation, oncology surgery for hepatobiliary malignancy, and minimally invasive surgery. So today he's going to talk to us about the current management of hepatocellular carcinoma. Professor Su, please.
Thank you, Chairman. Can you see my slide now?
Yeah, we can see your slide.
Okay. The topic given to me today is the surgical treatment of HCC. And today I'd like to focus on a paradigm change in surgical treatment of HCC. And so maybe a hepatologist has no interest about that, but I will explain a little bit about something happened in liver surgery. The anatomical resection according to the portal vein territory is the prepared procedure for hepatic resection, but for more functional and oncological surgery, you have to consider other factors. First, we should not cause hypoxia to the liver. And second, we should not induce rapid regeneration. And third, we have to consider future liver transplantation, so-called salvage liver transplantation. We all know that the liver resection for hepatocellular carcinoma should be an anatomical resection according to the portal vein territory. And because even in very small HCC, there is a high chance of portal vein invasion, and so daughter nodules can and the portal vein thrombosis develop. So this is a resected specimen. The patient already underwent TACE, and you can see the daughter nodules near the main tumors. So surgical resection is done according to the portal vein territories. There is a high chance to remove all tumor, including daughter nodules. But if you do RFA, sometimes the daughter nodule remains, and later it will cause recurrence around the main tumor and subsequently a decreased survival. You may know well about this. But today I will talk about other consideration which would be important in oncological surgical field. First one is hypoxia. This slide shows the established factors contributing to HCC progression. Among them, hypoxia is one of the factors promote angiogenesis and so HCC progression. Under hypoxic condition, hypoxia-inducible factor 1, FIF1, is stabilized and translocated into the nucleus and affects transcription of target genes responsible for angiogenesis and invasion and metastasis. In this patient, a small HCC was developed in around the right hepatic vein, and it was locally resected, but unfortunately, some biliary leakage developed and the middle hepatic vein was obstructed, and then congestion developed here. And just 4 months later, multiple tumor recurrence developed in whole liver. I experienced several cases like this, so I thought it may be related to hypoxia of the liver because this patient have a congestion due to middle hepatic vein occlusion, and then congestion means there is not enough oxygen to that liver. That means hypoxia. There are several clinical supporting evidences. Nagai et al. Reported long ischemia time is a risk factor for recurrence of HCC at the liver transplantation. And actually in LDLT, living donor liver transplantation, graft congestion sometimes develop due to hepatic vein stenosis. And our team reported that graft congestion was significantly related to tumor recurrence of HCC at the LDLT. And recently, Dr. Zhou in Bundang Seoul National University reported that the association of remnant liver ischemia at the resection with early recurrence and poor survival after resection in HCC in JAMA surgery. So when we do hepatectomy, we have to consider the inflow and outflow. Otherwise, the ischemia and congestion develop, so liver become hypoxic. This cartoon shows the inflow and outflow of the liver. Inflow, that means the portal flow enter the center of the liver segment, but outflow, hepatic vein, located between two segments. So you can see right hepatic vein is located between right anterior and right posterior, and the middle hepatic vein is located between right anterior and the left medial segment, segment 4. So when the conventional hepatectomy is done, some portion of hypoxia and or congestion may develop. For example, if you do left hepatectomy, including middle hepatic vein, the right anterior section will be congested. We should not make liver congested as far as possible. In this patient, the tumor compress the right hepatic vein or maybe invade a little bit. And the MRI showed the same finding. So in this case, we have to remove the tumor with the right hepatic vein. Otherwise, we cannot obtain free margin. But if you just resect the tumor in the right hepatic vein, the remnant right liver will be congested because the right liver drains most of the right liver. You may consider right hepatectomy, but in this particular case, left liver is very small, so we cannot do right hepatectomy in this patient. So my approach is that the tumor is removed with some portion of a right hepatic vein, some segment of right hepatic vein, and the right hepatic vein is reconstructed with the artificial vascular graft. So it is a postoperative CT scan. As you can see, there is no congestion or in the right liver. Secondly, we should not induce rapid regeneration. Under replicative status, stress after liver resection, genomic instability increase and the tumor progression is facilitated. In this animal study using rats, hepatectomy was performed to various degrees in groups of buffalo rats with concomitancy implantation of a fixed number of hepatoma cells in the remnant liver, and largest resection was associated with the increased hepatoma cell infiltration in the lungs and significant upregulation of cytokines such as VEGF. They suggested that liver regeneration after partial hepatectomy facilitates the growth and the malignant transformation of a microscopic hepatocellular carcinoma. So optimal amount of resection, smaller but adequate resection is necessary in terms of oncological view. Third one is we have to consider liver transplantation. It is quite difficult to dissect the hilum, especially in case of portal hypertension, if there is a history of previous liver or biliary surgery, especially if you dissect the hilum previously. This patient has a tumor in segment 7, very upper part of the liver near the diaphragm. It's a tumor is very upper part of near the diaphragm. This location used to be a contraindication of the laparoscopic surgery, but now it is not a difficult operation thanks to technical advances such as a 3D flexible scope. So now I will show you some operative technique. Right liver is mobilized, dissecting some inferior adhesions and peritoneal reflection, and the lateral part coronary ligament is dissected. And the liver is fully mobilized to the left. So we can, in that case, we can see the tumor like that. We can identify the tumor with the ultrasonography and the mark with the electric cautery with some, with the margins, sufficient margins. Maybe this is a tumor and the tumor margins like that, and then we apply some inflow occlusion for the liver resection, just for temporary occlusion of hilum, and then we can temporarily occlude the hepatic artery and portal vein for a while. We usually use 15 minutes of occlusion, and then with the CUSA we can remove. And then this is a pedicle, portal vein pedicle supplying the tumor. And we are now, I am divide this pedicle. So maybe portal vein territories of this one is removed. And then also is a hepatic vein draining this area. I'd like to preserve this main branch of hepatic vein, so not to make any congestion after the surgery. And tumor is removed. It's a very upper part of the liver, a very posterior and superior part of segment 7 tumor. And liver is finished. It will be removed with the endobag. And then this is a post-operative CT scan. As you can see, the tumor is well removed. There is no congestion or ischemia in the region. Patient discharged 3 days after operation. So in summary, for oncological surgery, we have to do anatomy resection according to the portal vein territories. Also, we have to consider such as a hypoxia problem. and degeneration problem, and future liver transplantation. And so from now on, I'd like to introduce some new technique in surgical resection. This patient has a huge tumor in the right liver, and the left liver is very small here. So we did a transarterial chemo radioembolization in this patient. As you see, tumor size subsequently significantly reduced at 3 months at the TARE, and then on the other hand, left liver is become bigger enough to do a right hepatectomy. So we did the right hepatectomy safely. So this is after surgery. You can see left liver is well regenerated, and there is no problem in postoperative course. And this patient has no recurrence up to now, or 2 years after resection. So another advance in liver surgery is introduction of ICG, indocyanine green fluorescence imaging. ICG used to be used to estimate the liver reserve function in the field of liver surgery. But another important aspect of ICG is that ICG entered the hepatocyte and excreted into the bile following preoperative intravenous injection. And the ICG accumulated in cancerous tissue of a hepatocyte cell, hepatocellular carcinoma, and in non-cancerous hepatic parenchyma around the adenocarcinoma foci. So we can apply ICG fluorescence imaging for hepatic tumor dissection, detection, metastatic HCC detection, segmentation, and cholangiography. This patient has the HCC in segment 6. Sometimes it is not easy to find the tumor with the ultrasonography, but ICG fluorescence imaging, you can easily find the tumor, and then liver resection with we can do liver resection with confidence with the enough tumor-free margin like this. So it is a tumor with a sufficient margin. This patient discharged 3 days after operation. In this case, is a tumor is caudate here, very difficult to operation, difficult to operate, difficult to find, and difficult to apply any other treatment. And then if you dissect a little bit, and then if you see through the ICG camera, you can find the tumor very easily, and then confirm with the ultrasonography, and then mark safe margin, sufficient margin. Then we can remove this tumor. Very quick operations, like 1.5 hours. We can finish this one with a sufficient margin, and the patient discharged also 3 days at the operation. And this patient actually has drum metastasis of HCC. As you can see, this is the original tumor. THC was done, but there is some dissection also done, and then there is a drum metastasis here. So we'd like to remove that one. But actually, it is not easy to find that kind of drum metastasis. So if you, it's an open surgery, but I just use ICG camera. And then if you dissect a little bit, upper part, some capsule, and then you can find the tumor here. So it is very it's convenient to find the tumor like that. Sometimes the lymph node is positive, and then if you use ICG camera, you can see the positive lymph node very well. Also, we have a robotic surgery nowadays we can do some segmentectomy with the robotic surgery. Is a 1.4 centimeter tumor in the segment 6. It's here, and then at this time I applied the robot surgery. As you can see, we can dissect very gently, very delicately with the robotic arm. And in robotic surgery, ICG imaging is launched included in the robotics system. So you can find the tumor with the ICG, and then we can dissect the tumor with the confidence with the margin. You can remove very easily, very quick operation, and then you can see the tumor with a big margin here. Also, we can demarcate the liver segment with the ICG. We temporarily occlude the right hepatic artery and portal vein, and then inject the ICG dye, and then we can see the left liver. You can see the demarcation very well. It is very important for surgeon to do exact lobectomy. And then after that, the ICG is excreted through the bile. So you can see the bile, which is a kind of ICG cholangiography. We can do that, and then it is very useful to find the right hepatic or left hepatic duct during actually donor surgery. So with this technical advances, donor operation, live donor operation is done laparoscopy in my center in most of cases. As you can see from November 2015, more than 80% of cases of donor surgery were done by pure laparoscopic hepatectomy, and until now we have done 418 cases. And as you can see, the main advantage of laparoscopic surgery is excellent cosmetic outcome. This is the donor I saw recently in my OPD clinic, and then I could not actually recognize the wound well. But this slide shows the survival curve after surgery and liver transplantation. As you can see, survival is continuously decreased in the resected group. Otherwise, on the other hand, the survival after liver transplantation remains stable at the initial drop. So that means we need something to do. We need some advanced treatment to do to reduce recurrence after recurrence. And Lee et al. Has published the outcome of immunotherapy with cytokine-induced killer cell in gastroenterology 2015, showing significant recurrence lowering effect of CIK cell. Also increased survival in CIK group. So it is my conclusion. We have to consider functional and oncological liver resection. We have to do anatomical resection according to the portal vein territories. Do not cause hypoxia to the liver, do not induce lipid regeneration, and consider patient comfort and the future liver transplantation. TARE may replace the TAC and portal vein embolization package, which used to be done for safe liver resection when small liver is expected. And ICG fluorescence imaging guided surgery is already very popular, but anyway, it is very useful technique in liver surgery. Still, we need something to measure, some measure to reduce recurrence after surgery. Anyway, thank you very much for your attention.
Thank you very much for your excellent presentation. Many new ideas to the surgeons. Well, maybe we can answer some questions. Is there any questions from the audience? If not yet, then may I ask you, Professor Shu, about the question on the hypoxia. So do you consider Pringle maneuver as a form of hypoxia to the liver?
Yeah, it's I don't think so much about the Pringle maneuver. It is only 15 minutes, 15 to 30 minutes sometimes. 15 minutes and 15 minutes off, and then it is a very temporary hypoxic condition. I don't know if we continue. If the time is prolonged, maybe it affect some to the liver condition, but just the 2 or 3 times Pringle maneuver, we don't have any evidence about that is harmful to recurrence.
So we can use Pringle maneuver routinely and without any consideration of inducing tumor to form.
Yeah, I think so. But if you make a hypoxic injury to the liver for a long time, maybe it causes some, may change some liver environment, and then maybe some dormant HCC focus or some microscopic HCC maybe will develop after this cytokine change.
Right. So the other question is about the abbreviation TARE. What is TARE?
Transarterial radioembolization.
Radioembolization.
Yeah, radioembolization.
So it's more effective.
Yeah, it's very expensive, but sometimes very effective to reduce tumor, and then the other side of liver become hypertrophic, and then can affect tumor with the same.
Yeah, we have seen that too, but it's a bit expensive.
Very expensive, yeah.
Okay, so is there any other questions?
Yes, it's nice to see you.
Dr. Sarin.
This is Dr. Sarin, and I enjoyed the surgical techniques. I'm a medical guy, but I still enjoy the new technique. Can you hear me, Dr. Su? Can you hear me?
Yeah, you can. Yeah. Now it's okay.
Can you hear me?
Yeah, yes. Now.
My question. I enjoyed your talk. My question is: you have a patient with mixed hepatocholangio, mixed tumor.
Yeah.
And, do you have any criteria in a patient with a mixed hepatocholangio, especially with involvement of like VP3, one tumor invasion of one branch and a mixed hepatocholangio? How would you approach such a patient? I mean, the size is around 5 to 7 centimeters and a mixed hepatocholangio with one branch of portal vein involved. It's very common now for us to see this.
I can hear you. Half of your voice is mingled, but anyway, you means there is a mixed tumor in one branch of the portal vein, right? And then what is the treatment in that case, or what do you want?
Surgical approach to a mixed hepatocholangio.
Yeah.
Mixed hepatocholangio with one branch of portal vein.
Yeah, we can resect anyway. Is also cholangio. We favor a resection, and the mixed tumor. We don't know that is a mixed tumor or not preoperative very well. If you do. Otherwise, biopsy show that, but otherwise we do not do biopsy preoperatively. But there is a sign of mixed tumor in radiologically. We can suspect that it is maybe a mixed tumor is a kind of some cholangio component is in there. But my approach in that a mixed tumor is the same as a hepatocellular carcinoma. But maybe it is the prognosis a little bit low, is bad, but still we apply same surgical technique and the same liver transplantation indication in mixed tumor too.
Okay, so there's a question.
In the liver transplantation about a month ago, a large series from New York. And I was very happy to see that the surgical outcomes are same. We were always afraid of getting hepatocholangio operated. But now we feel very confident that surgery can be done in them. So thank you.
Okay, so there's a question from Dr. George Lau. Professor Su, when to use the robotic? So what is our choice?
So actually, we don't need a robot right now. Actually, we can. Actually, for me, laparoscopic surgery is more convenient. But we have a robotic surgery, and then this technique will be developed more and more future, and then better robotic surgical arm will be introduced. So I'm just somebody want to robotic surgery, I do, and then I am preparing the future just.
Okay, so the final question: what is the dose and timing of ICG for picking up small HCC not visible by intraoperative ultrasound?
Yeah. It's if you we usually do ICG test for the liver remnant liver function 2 or 3 days ago before operation. So if you do it very 1 day before, in some bad liver show the whole ICG staining. So we'd better do it maybe 3 or 5 days before operation. Just we are testing those of ICG, and then we can see more clearly in the operation field the tumor accumulation of ICG. In case of segmentation or just a bile duct cholangiography, we just inject 0.025 milligram per kg in the operation room, and then you can just see within a minute you can see the segmentation, and maybe 1 hour later you can see the bile duct.
All right. Okay. Good. So I think we have come to the end of the meeting. So thank you very much, Professor Su, for the excellent presentation. Thank you.
Thank you very much.
Thank you.
I would like to take this opportunity to invite all the users to attend the APASL 2021.
Save the day.